attention, it is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
2, 3.
Good morning, everybody. That was Leonard Skinner singing his greatest hit ever, Sweet Home Alabama. This is Dr. Minarsik who will be singing to you about the pancreas today. This is our 59th full 2-hour global medical school pathology session, and it's Thursday. It's April 5th. And this is what's known as, in the Christian calendar, Holy Thursday, the day of the Last Supper. It's 9:03 a.m. in Chicago, and I think we're about ready to do our test before I make a couple of very small announcements. So you know the drill by now. The first part of the test, and it's not multiple choice, is, can you hear me? Okay, we got that one right. Second question is, what do you see? Lagomorphs. I like that. Yeah, I guess they are. I think I remember those from basic biology way back when in the Stone Ages. Okay, everything is working fine. So this is the time to make a couple of very small announcements. The first announcement is that some of the music that we're going to have today was supplied by one of our students, Andrei Zharov from Russia. So when we take our break, the first song you're going to hear, a little bit late for St. Patrick's Day, will be sent to us by Andrei. And once again, I encourage people to send me awesome MP3s. Second and last announcement is something I keep drilling on, and I'm so proud of it. I'm going to pop open the screen here. This is a web page. This is the amount of videos that I have uploaded so far to my website. So you might see that when you go back a page, you're at my website, which is Medical School Pathology. And by the way, do you see any ads on my website? Do you see anything that says sign in or register or give me your name or give me your phone number or what's your credit card number or anything like that? This is free, 100% accessible information that could be shared by anybody with no hassle and no ads. This is what the internet was meant to be, okay? Before the capitalist pigs bastardized it, we had a really nice concept here called free sharing of knowledge. And some of that free knowledge here is now I have not only last session, 58, but in a couple hours after this session, you're going to see the session here online as well. And I've gone back all the way to 37, and probably by the end of the week, probably by Easter Sunday, I'll be down to session number 1. So the entire course. The reason why I'm so proud of this is the actual videos are an extreme high resolution audio and video, and they're actually better than the live sessions, I've been told by some students. Just want to ask one simple question here. Has anybody downloaded any of those MP4s yet that are up there? Okay, for the person that has said they have downloaded it, can I ask you that question? It's somebody named John. I can't see his last name, but I know he always gets all the answers right. John, let me ask you a question. Were the videos actually better than the live sessions in terms of quality? He says yes, and that's exactly what I thought. So you see that? I have just lost my live audience because they realize it's better on Memorex than it is live. But, you know, remember, once again, it's always better to go to the live concert rather than listen to the stupid record at home. So keep coming back. I'm going to talk about the personality of our topic today. I'm going to talk about the personality of the pancreas. It's the first of all, it's the shortest chapter in the book, and that makes it nice because not only can I spend more detail on normal features of the pancreas, but I could do the entire lab as well as the lecture today. I know I'm going to do it. And the pancreas is something, with one exception, I would say is probably the cleanest, simplest, easiest organ, as well as being the shortest chapter. The only thing that's complicated about the pancreas is to visualize its intimate relationship with the duodenum. it would be inconceivable to resect a duodenum without a pancreas, and it would be inconceivable to resect a pancreas head without a duodenum. That's why they are always done as one. Same blood supply, same area, and sometimes a lot of things in gross anatomy are easy to visualize because you can see them, you could feel them, but you'll never, ever, ever be able to differentiate the head of the pancreas from the duodenum, no matter how good of a dissector you are, because it just doesn't exist. So that's our topic for today, pancreas. It's something that probably a lot of pathologists would volunteer for because it's clean and easy. Here we are. We started out in September with cell adaptations here, and then somewhere around Christmas time we finished the first 10 chapters, which are general path, and now we're well into the home stretch, I think, of systemic path. And remember, we've already dealt with kidney when we were in the Caribbean, and we've already dealt with central nervous system in Lab 2, and the eye chapter is always done by my son. So what I'm thinking is that there's only about 1, 2, 3, 4, 5, 6, 7 chapters left. 2 of them are pretty long. The others are relatively short. So when I get to pancreas, I'm thinking I'm in the home stretch, and it's a good feeling. So it's pretty obvious what our objectives are today, the same as the objectives we've had for all the other chapters, is to understand the 4 classical features that make a disease, and understand the etiology or risk factors of pancreatic diseases, the pathogenesis or cellular changes that occur even prior to the development of symptoms. We're going to talk about the morphology, gross and microscopic, and then the clinical features. You know, somebody said to me, gee, pancreas is such a short chapter. All you got to talk about is pancreatitis and pancreas tumors, pancreatic carcinoma. In a way, that's true. So it is going to be basically focused in on those 2 topics. So we'll be able to dissect a little bit more into the normal things. And of course, one of the first normal things we always deal with is embryology. If you remember, we talked about all of the foregut structures and branches of the foregut when we talked about liver. Same thing is true with the pancreas. There is a outpocketing of the gut tube called the foregut before you get into the dilated area, and this is the area which will eventually develop into the duodenum. And there's 2 buds that arise from this area. There's a ventral bud and there's a dorsal bud. And everything we talked about in the last 2 sessions, liver and gallbladder and bile ducts, develops from the ventral bud. So you have, once again, an outpocketing of foregut entoderm, which eventually gives rise to the entire hepatobiliary tree, including gallbladder. But guess what? There's also a little portion of pancreas that develops from that as well. And in addition, on the other side of the precursor to the duodenum is a dorsal pancreatic bud as well. So here we go, and these things are budding and these things are developing, and here we go. Now we have the hepatobiliary tree. Here's the liver, here's the gallbladder, here's the ventral bud. We also have the ventral bud outpockets right from the beginning of the common bile duct, which of course it should be, because that's where it is in adult life too. But then we have the dorsal bud, and guess what? They fuse eventually. This ventral portion sort of turns, it joins up with the dorsal portion, and bingo, these 2 things then develop into one pancreas. And that's why there are classically 2 ducts to the pancreas. The one that was the dorsal bud winds up having this little accessory and often absent duct called the accessory pancreatic duct, still connected with the duodenum. In the old days it was called the duct of Santorini. And then we have the ventral pancreatic bud emptying into the origin of the common bile duct to form the main pancreatic duct. So here we go, and now you have your pancreas. And that's why we have sort of a dual duct system. They adjoin together eventually throughout the body and tail, but in the head portion there's definitely 2 buds. two duct systems, and even in adult life, this little dorsal connection, the duct of Santorini, may even be patent, but the main duct from the ventral bud comes into the ampulla with the common bile duct as well. Okay, so here we are back to our normal picture again. Something I wish you could just look at this and visualize it rather than describe it, but this is never what you're going to see when you dissect out a cadaver, because it's just so perfect. All of the arteries here and all the relationship to the aorta and duodenum, and look how in the process of that dorsal and ventral bud fusing, look how it almost wraps itself at least maybe 50 or 75% around the sweep of the duodenum. Here it is opened, you can see the plicae, and this is the tail of the pancreas going towards the spleen. And at this point it would probably be better to look at something that's a little more realistic, because now here's the posterior view of the pancreas and all of the structures that are involved. Look how that head of the pancreas is just plastered around the medial aspect of the sweep of the duodenum. And then here we are, here's the so-called duodenal bulb, which may be the only portion that's intraperitoneal. The entire rest of the duodenum is retroperitoneal. And then of course once you get into the jejunum again, everything is intraperitoneal again. I'm going to do a quick review of some of the blood supply, and it's very complicated unless you look at it this way. There's basically 3 arteries that supply the pancreas. 2 of them supply the head, and the body and tail is supplied by the 3rd one. Now, the 3rd one is real easy, because you know that splenic artery runs throughout the course of the pancreas, goes all the way to the tail, and then feeds the spleen. So there are branches of the splenic artery. Of course, the biggest one is the dorsal pancreatic artery coming off the splenic, but there's usually a few others. So that's basically the body and tail of the pancreas, the splenic, because they're just lie right on top of each other. Now, in the head of the pancreas, it's a little more complicated. You remember that there is a common hepatic artery as one of the main branches of your celiac axis, and that will give rise to a superior pancreatoduodenal arteries, and that will branch both posteriorly and anteriorly. And guess what? Now we're into a whole different artery, the superior mesenteric artery, only 1 finger below the celiac axis, and that also has now an inferior pancreatoduodenal artery, and that divides into an anterior and posterior branch as well. So this is another very clear-cut example of anastomosis between the celiac trunk and the superior mesenteric, and it very reliably does this. There's very few variations to it, I'm told, by the surgeons anyway. So that's your blood supply. The venous supply is all 100% portal drained. You have your splenic vein coming in, you have your superior mesenteric. Somewhere along the line you got your inferior, and they all join together right there in the mid portion of the pancreas to form that big portal vein. And of course, everything there is a branch to it. They're not nearly as reliable in anatomy as the arteries are, as always. Here is the lymph node drainage to the pancreas, and I'll tell you, even though it's somebody in the art shop here was very nice in drawing red celiac access nodes and light blue superior mesenteric nodes and darker blue pancreatosplenic nodes and purple pyloric nodes, and even some biliary nodes running along the hepatic artery. It really doesn't work that way. When a surgeon does a Whipple's, he'll very rarely differentiate those nodes, and for all practical purposes, these are all called peripancreatic lymph nodes. That makes it much simpler. But just to let you know that, some brilliant anatomist decided to divide the peripancreatic lymph nodes into 5 different groups because he wanted to seem like he was smarter than everybody else. Here is a nice artist conception. And remember, in the vast majority of cases, the pancreatic duct empties into the very terminal portion of the common bile duct. Sometimes it enters separately, sometimes it enters higher up, but most of the time this is the probably 90% pattern of the pancreatic duct entering into the ampulla ultimately, which is the where it joins the common bile duct. Now remember this. Do you see how some of these muscle fibers here are circular? Well, that would qualify to be a sphincter, wouldn't it? So not only do you have a main sphincter of Oddi, O-D-D-I, I think it's spelled, was the old name, but if you rather call it the sphincter of the hepatopancreatic ampulla, you could, or even the ampullary sphincter, you could. But there are also separate sphincters for the common bile duct as well as the pancreatic duct, usually. So even though both of these tubes enter into the ampulla and they have their sphincters, they all have their individual sphincters as well. And think about that. There are physiologic mechanisms that control these sphincters. And let's just say, for example, that there was a stone lodged right there, because it's a big stone, it couldn't pass through easily. So therefore your common bile duct is blocked. But let's say technically your pancreatic sphincter was not blocked. You would then get backup of bile into the pancreas, wouldn't you? And guess what, folks? That's the 100% consistent finding in pancreatitis. So bile reflux is experimentally and factually the main reason for pancreatitis. Of course, it has other factors too, like alcoholism, but pathophysiologically, anatomic speaking, if you reflux bile into the pancreatic duct, you're going to produce pancreatitis. Here's that sphincter from the GI doctor's point of view. The endoscopist sees all these nice plicae in the duodenum, and of course you'll see that little nubbin popping out. And by the way, there may be a stone popping out of there. The endoscopists very frequently take out little stones. They can also manipulate into the bile duct and even the pancreatic duct a process known as ERCP, and it's a very, very delicate procedure. But remember, that's a pretty good size sphincter there, and it's might be surprising to you, but even a stone that's like, let's say, a half a centimeter wide, can pass through that. It has a lot of opening power to it. Here's that same pancreas now drawn as a diagram, and just look at the relationship of all of these neighboring structures. The tail is near the left kidney and the spleen. There may be some loop of small bowel. There's usually a big stomach laying on it to the left anteriorly. Some more loops of bowel, small bowel, large bowel. Here's your duodenum, right smack dab married to it right here. Here's your pancreatic duct. You might see a common bile duct. We're going to be looking at some CT images. And of course you have your big liver, your big spleen, and the other kidney. Aorta right underneath it. Inferior vena cava just to the right of that. The vertebral body that is consistently the closest to the pancreas is usually L2. Sometimes it's L1 or L3, but it's usually L2. So it's not surprising that if a pancreas carcinoma metastasizes or extends to bone, the most likely bone that it will metastasize or extend to is the second lumbar vertebral body. That's an old radiologist trick as well. Here's a pretty good quality CT. You can see your kidneys, you can see the cortices, the medulla, the vertebral body. You can see the nice aorta around here. You can see the head of the pancreas. Here's a nice stomach with the fluid level in it. Here's a nice gallbladder over here. And here's your body and tail of the pancreas. Sometimes you could pick out some pretty good structures. I don't know if this black thing here, it was meant to be the common duct. It could very well be, or whether it was somebody that wanted to draw an arrow, like somebody drew an arrow over here. But these are the general structures. Here's some fluid that just happens to be gravitationally, so you know this person got the scan laying on his back because the air is on the top. Here is another, perhaps better, CT of the abdomen. Once again, you got your stomach. Once again, you have a beautiful head of the pancreas. We have some nice lobulations going down to the tail. There's the tip of the spleen. There's the liver. There's a kidney. There's part of another kidney. And remember, the right kidney is usually a little bit more inferior than the left. And if you think that it's because the liver is there and pushing it down, that's the correct answer. Here's your aorta. It looks like this could very easily be part of a superior mesenteric coming out over here. And looks like this might even be the IVC, because it has the same signals as the renal vein over here. So this is another nice picture. And once again, there's a little bit of air left in the stomach as well, isn't there? Okay, let's drop down to histology now. Even a very experienced person, when they look at a pancreas, might think it's a salivary gland that has 100% serous acini, like the parotid gland, unless they see islets of Langerhans. Basically, it's your classical endocrine structure. There are lobules. There are these individual acini within the lobules. Here are your acinar cells. There are cells that start to form the duct system, which are called centroacinar cells, which make the bicarbonate. You're going to need a hell of a lot of that because you're going to be neutralizing stomach acid at the end of this trail here. And then both the intercalated ducts and the intralobular ducts are within the pancreatic lobules. If you see a duct that's between lobules, completely within fibrous tissue, that can be called an interlobular duct. And every now and then you'll see islets here, and of course the islets aren't going to be at all connected with the duct system. And we're not going to be talking about diseases of islets today either. We'll be talking about that when we get to the endocrine portion of the course. And basically there's your histologic diagram. Now here's a real histologic picture of a couple of acini, and look at, you see those round nuclei at the base of the cell? Those are your acinar cells. Here are all your granules. That's making all the different enzymes needed to start the digestive process. These more spindly cells, probably here, definitely here, probably here, are the centroacinar cells, which are the beginning of the duct system, the powerful bicarbonate makers. Here's a nice electron microscope showing the lumen. Here's some round acinar cells. I don't know if I see any centroacinar cells here, but I certainly see a lot of zymogen granules about ready to be emptying into the lumen here. And here's a nice regular, more real type of picture of nice pancreatic acini within the lobule. You know this is only part of a lobule. You know it's not an entire lobule because lobules are separated from each other by connective tissue. And this is almost entirely acinar tissue. So once again, the round nuclei are the cells of the acinus. The ones that are a little more spindly, perhaps over here. If you notice, the spindly cells have a same type of cytoplasm as the intercalated ducts, which are the smallest ducts, which are over here. And this may either be an intercalated duct or the beginning of an intralobular duct. Personally, I think it's an intercalated duct. But both the intercalated and the intraductal are completely intralobular, are completely within lobules. So what are those granules? Well, it's every single thing you need to digest all three basic food groups: proteins, carbohydrates, and fats. So amylase is always at the top of the list. It's also the main diagnostic enzyme used in pancreas disease, because injure a pancreas, and these enzymes are going to come out into the bloodstream because of the injury. So that's a very sensitive but non-specific indication for pancreatic disease. Lipase, digesting fat, amylase digesting starch, your nucleases digesting DNA, RNA, your protein digesters, your zymogens, trypsinogen, chymotrypsinogen, and your procarboxypeptidase. All your food groups are represented by those granules because that's where the digestion starts. So, are we ready to talk about pancreas diseases? Yeah. And even though we said that pancreatitis and pancreas cancer are the main focus, we'll say a word about congenital diseases. We'll differentiate acute from chronic pancreatitis because they're two completely different diseases. One is usually subclinical and the other is often fatal. You know, there's a big difference between acute and chronic pancreatitis. We'll talk about cysts, and of course in the field of neoplasms we'll look at a few interesting ones, but the big one of course is pancreatic adenocarcinomas. Virtually all of the neoplasms of the pancreas are glandular in origin, whether they're benign or malignant, simply because the pancreas is 100% gland. Well, it's theoretically possible that you never get a pancreas. As you might guess, it's very, very rare. It's also inconsistent with life. I've never seen one in a newborn or fetal autopsy. I know it's very, very rare. If you remember, when we have that little twisting of the duodenum and the ventral bud is supposed to fuse with the dorsal bud, sometimes it doesn't happen. In that case, it's called a pancreas divisum, or failure to fuse, and that's relatively common. Very often it looks like there's sort of two pancreases and they're just partly joined. It's more likely to be that way than two completely separate pancreases. Now, I've already told you that the pancreas kind of wraps itself at least 50 or 70% around the duodenum. Sometimes it wraps itself 100% around the duodenum, and that's called the annular pancreas, and that's also relatively rare as well. Now, the thing that is very, very common is ectopic pancreas. And if you remember when we talked about congenital diseases of the stomach, congenital diseases of the duodenum, congenital diseases of just about any abdominal organ, it's very often that you see little remnants of pancreas tissue, because sometimes in the embryologic development of the pancreas, little nests of pancreas are kind of just stippled in other organs. And even though this is usually not clinical and usually not harmful and very, very, very common, I bet you if you did 100 autopsies, very, very well, probably in about a third of them you'd find little ectopic pancreas somewhere or another. The reason why it's really scary is because when a surgeon is in an abdomen, he sees these little nodules, he's thinking, oh my God, what is this, metastatic disease or what? So he sends them to us and we say, don't worry, it's just a little bit of ectopic pancreas. It's very, very common. Okay, so here's when the dorsal and ventral blood, before they fuse, and here they are when they fuse, and of course when they don't fuse, that's called divisum. Okay, now we're into one of our two main topics, and that's pancreatitis. Acute pancreatitis and chronic pancreatitis. In a way, two different diseases. Of course, chronic pancreatitis can follow acute pancreatitis, but clinically, the patient with acute pancreatitis is in deep trouble. It has a high mortality. Whereas chronic pancreatitis is often seen in people that are subclinical and they don't even know they have it. And the radiologist may pick it up by doing a CT, and they see that there's a lot of little stippled calcifications conforming to the outline of the pancreas or in the pancreas area. And that may tip them off that somewhere along the line there may have been acute. But chronic, of course, can happen all by itself. It does not have to be preceded by acute. And then, of course, there's this concept of pseudocyst. So whenever you hear the word pseudocyst, you're almost always going to hear the phrase of the pancreas following it, because pseudocysts in general are regarded as the result of both acute and chronic pancreatitis, but mostly chronic pancreatitis. So let's break it down a little bit more before we get into the causes and the appearances. Acute pancreatitis, very, very, very severe disease. Your pancreas is being destroyed acutely. It's hemorrhagic. There might be some infiltration of neutrophils. All of those digestive enzymes, which are supposed to digest food, are now digesting your abdomen. Okay? That's the basic reason. So all of your tissues, your fat, your proteins, your carbohydrates are all being digested within your body. That can very often set up the setting for shock, DIC, adult respiratory distress syndrome, acute renal failure, all of these things associated with severe terminal events. Okay? It can also result in a pancreatic abscess. It can also, especially if it goes through a chronic phase, result in a pancreatic pseudocyst, which we're going to go to in more detail. And of course, with all that edema there and all that swelling and all that hemorrhage, it also can produce not only duodenal obstruction, but even duodenal digestion. Okay, this is a very serious disease. Now, let me say a word about pancreatic abscess and about acute pancreatitis in general. You remember that we have told you classically, time and time again, that the hallmark of acute inflammation are neutrophils. And now you see that if acute pancreatitis can lead to pancreatic abscess, there must be a lot of neutrophils involved. And the answer, of course, is yes. However, the main gross and microscopic appearance of acute pancreatitis is not neutrophils, it's not pus, but it's hemorrhage and digestion of itself, something called autolysis, digestion of itself, and also a concept called saponification. Your pancreas and the surrounding tissues turn to soap. And it's a very simple chemical, understandable reason for this. Okay, now here's chronic pancreatitis. Chronic pancreatitis is assumed to be present 100% of the time whenever a patient has a pseudocyst. In chronic pancreatitis, one of the causes of it, both acute and chronic, are not only bile reflux, but duct obstruction as well. So in chronic pancreatitis, you may see large duct obstruction. Functionally, a chronic pancreatitis might result in malabsorption and steatorrhea for the simple fact that the pancreas just isn't working. It's not doing its job to start digesting fats and other things. So we talked about the whole long list of reasons why the bowel might have malabsorption tendencies, but now we have something that's called pre-bowel malabsorption, and that's chronic pancreatitis, or acute, and also secondary diabetes. We can't ignore that. If you have enough damage to the pancreas, even though if that damage is primarily to the exocrine portion of the pancreas, very, very often you're going to have damage to the islets as well. And you know that damaged, non-functioning islets mean diabetes, secondary diabetes. So these are your consequences of acute and chronic pancreatitis. Now, let's go to the big one, the dangerous one, acute. Acute pancreatitis usually occurs in alcoholics. It usually occurs in alcoholics that have been on a big binge on the weekend, and towards the end of that weekend, maybe even Monday, they develop severe abdominal pain, perhaps shock. And even though alcoholism is associated with it in terms of overall statistics, one of the things that's almost always present with any type of acute pancreatitis, and even chronic, is bile reflux. Now, once again, you pour bile, and the bile doesn't go into the duodenum, it turns around and goes into that pancreatic duct, you're going to cause acute pancreatitis. Some of the medications, the thiazides are the most notorious, being associated with pancreatitis. People with acute pancreatitis very often have a setting of high calcium and high triglycerides. And think about it. Wouldn't it be logical that if there was ischemia to the pancreas, you're more likely to produce damage as well? So acute ischemia is another factor. Isn't it logical to think that if there is blunt abdominal trauma or extensive surgical instrumentation, that mechanical process itself might also cause acute pancreatitis? It also would not be fair if we didn't mention that there's a couple of genes that are always regarded as mutated or defective or absent. One of them is called the PRSS1 gene, and the other one is called the SPINK1. I don't know what they stand for. I did sometime. It probably doesn't matter. But probably in 90% of the cases of acute pancreatitis, one or more of these factors are present. Alcoholism, bile reflux, medications of known pancreas damagers, extreme hypertriglyceride or calcemia, ischemia, trauma. But in about 10%, none of these factors are present. So we'll say it's idiopathic in about 10 to 20%, and the other 80%, one or more of these factors are present. Clinical features, very often severe abdominal pain, very often shock. You are having a hemorrhagic digestion of your pancreas and everything around it. It has a very high mortality. And of course, diagnostically, clinically speaking, this almost goes without saying. The single most important lab test, besides all of these symptoms, perhaps a history of an alcoholic binge, is amylase. And that's pretty obvious. Amylase is a carbohydrate digesting enzyme. It's prominently made by the pancreas. If you remember, it's also made by the parotid or salivary glands as well. And very often the amylase is sky high. Okay, the problem is, in just about any type of abdominal injury or trauma, very often the amylase is elevated just a little bit, even in renal diseases, even in, any probably if somebody kicked you really good in the stomach right now, you'd probably have some elevation of your amylase. And a really, really rock sky-high amylase probably means pancreatic disease. But let's just say minor elevations of pancreas, maybe only 1 or 2 times normal, rather than 10 times normal, probably could be to a wide variety of things, many of which are non-pancreatic. Okay. Morphology now. That's what we like to show you. You got an acute hemorrhagic self-digesting process there. So you have edema. You have fat necrosis because your fat is being digested. You may have an acute inflammatory infiltrate, and you know that means neutrophils, but the primary picture is not the neutrophils, it's the hemorrhage. Okay, you have hemorrhagic destruction of the pancreas. Usually the word hemorrhagic precedes the word acute pancreatitis, because what the main process is autodigestion. All of those enzymes are now digesting itself rather than going down the ducts and into the bowel. Saponification is a very easy concept to understand. You have an enzyme called lipase, which splits fats into glycerol and triglycerides. Now, do you remember that the main triglyceride is a stearate? Okay? What happens if you have free stearates now floating around in your pancreas and in the surrounding areas? Well, what happens is that if it becomes linked to sodium, you have sodium stearate. Sodium stearate is soap. Okay? They take the animal fat and they combine it with sodium, and that's soap. On the other hand, if your stearates combine with calcium, you then don't have a soluble sodium stearate, but now you have an insoluble calcium stearate. And guess what? Calcium stearate is soap scum. That's your bathtub ring, okay? That's that gritty stuff that you see. So now you're seeing that gritty soap stuff inside your pancreas and inside your abdomen if it combines with calcium. If it just combines with sodium, it's regular old soap. And that's the way I have always understood it chemically, and that's my story, and I'm sticking to it. Here's a nice gross picture of an acute pancreatitis. Here's the head. Here's possibly a very large blood vessel. I'm not too sure. There's hemorrhage along here. There's yellow stuff there. Could that possibly be saponification? And there's your tail there. Now, I don't know if you've ever seen gastric contents where you see partially digested pieces of food. You might say, are you sure this is a pancreas, or was it maybe a large piece of steak, taken out of the guy's stomach? Well, they're basically the same thing, because now the pancreas has turned into food and it's digesting itself without even going into the digestive alimentary tract. How do you like that? So that's a classical picture. This could possibly be enough damage here to be fatal. Okay, now microscopically, you're going to feel cheated. Microscopically, you're going to say, hey, why the hell is he showing us this stupid picture? It's blurry. There's no nuclei. It's fuzzy. It's out of focus. Why the hell would he be showing us this? Well, the reason why I'm showing you this is because these are not viable pancreas cells, and this is not viable fat. This is partially digested fat. This is partially digested pancreas. They have no more nucleus. All you have is hemorrhage, partially digested protoplasm, and partially digested fat. Now, let me ask you this. Do you see a lot of neutrophils here? No, you don't. What you see mostly is necrotic tissue and hemorrhage. And even though acute pancreatitis can evoke, at some point in time, a big neutrophilic infiltrate and even an abscess, the classical findings of acute pancreatitis are chiefly hemorrhage and undefined cellular borders. If you want to call it necrosis, if you can. The proper term that is used is autolysis, and that means digestion of itself. Now, there's two kinds of autolysis. This is called pre-mortem autolysis because it's occurring in an organ, technically in a patient that hasn't died yet. But there's also something called post-mortem autolysis as well. For example, if a patient dies and you wait for a couple of days to do the autopsy, one of the normal things to happen after a patient's die is for some of these enzymes to break up and start digesting the tissue by itself. This is post-mortem autolysis. So very often when a person would die, when we were residents, they would want us to do the autopsies right away, because if you waited for a few days, you wouldn't get good slides of the pancreas. Another place that autolysis occurs are in the endocrine glands, especially the adrenal medulla. But autolysis can occur in many places in the body, but the most prominent and earliest place it occurs after death is in the pancreas. Okay, let's talk about chronic pancreatitis. Like acute, it's associated with mutations in PRSS1 and SPINK1 as well. Okay. It's often the result of long-standing duct obstruction. Let's say you have a stone. Let's say that you have some inflammation of the duct. Let's say that you have a duct that's inspissated with mucus. These are some of the features in chronic pancreatitis. And also, chronic pancreatitis can occur in a tropical setting, and I don't know why, but very often you'll hear the term chronic pancreatitis in tropical areas. Now, whereas in about 90% of acute pancreatitis we knew the associated factors, but in chronic pancreatitis is a little more mysterious. That a lot of these factors are not present. The one thing that is consistent with both acute and chronic pancreatitis, however, is alcoholism. Here's a chronic pancreatitis. What do you think these little white patches are? You think that might be a little bit of soap too? Sometimes these areas can even calcify. It's hard for me to show you how much of this is like sort of a saponified fat and how much of it is calcium, but I would imagine the whiter, darker stuff like there. I'm going to pop this window open. Do you see that in this little white blotch here there's like a denser, whiter area in the middle? That's calcified material. And look, do you also see it here in the middle? That's calcium. And in a lot of these, the calcium may just be very stippled. So radiologically, when we looked at that nice pancreas on CT, when you start seeing little pieces of calcium speckled throughout the lobules, you know that that is chronic pancreatitis. And by the way, as long as we use the term lobule, I'm going to show you. Do you see this little lobule of pancreas that's separated by fibrous tissue? That's a lobule. That's a lobule. That's a lobule. That's a lobule. So any duct within these lobules is called an intralobular duct. Any duct that's between lobules and lying completely within fibrous tissue is an extra or interlobular duct. Here's a chronic pancreatitis. What is the chief microscopic feature of chronic pancreatitis? Well, it's fibrosis and chronic inflammation. Now, take a look at these ducts here and here. Is this an intralobular duct or an interlobular duct? This is intra, because this whole thing is a lobule. But look, the lobule is infiltrated by fibrous tissue and chronic inflammatory cells. So sometimes, even though you know this entire field is filled by a lobule, the amount of fibrosis within it might give you the appearance that it's several lobules. Okay, big deal, who cares? But the most important thing is whenever you look like you're having a loss of the lobular configuration and these little acini are kind of freestanding within fibrous tissue, you are usually very, very worried that this might be pancreatic adenocarcinoma, because tiny infiltrating glands of a well-differentiated pancreatic adenocarcinoma can look identical to the small glands involved with chronic pancreatitis. Here, let me give another example. Let's say somebody stuck a needle into this pancreas and they send it to us, and this little area here is the only area you see. Well, what do you see? You see a couple haphazard glands infiltrating fibrous tissue, and then you're supposed to tell the surgeon if this is cancer or chronic pancreatitis. And believe me, sometimes it could be very, very difficult. In fact, our greatest nightmare is to see a few infiltrating looking glands, call it cancer, have them do a Whipple's procedure, which has about a 10% mortality rate. The patient loses half of his abdomen, sometimes even the spleen. They do a duodenum, and then look at it next day and say, whoops, it's only chronic pancreatitis. You lost half of your guts for no reason. Bingo, within 24 hours, you're getting served with a malpractice notice. This is every pathologist's nightmare, and actually, I know of a couple that it happened to. Here's some more chronic pancreatitis, and once again, the reason why on low power you'd probably call this chronic pancreatitis is because even though there's a lot of fibrosis in it, it looks like most of the acini are still generally following a lobular configuration. Even here, there's a lot more fibrosis in this lobule, but in general, these glands are kind of clumped into, a lobular pattern. And of course, here you have a duct You don't know at this point whether it's intra or interlobular, but it's probably inter because it's so big and it's completely surrounded by fibrous tissue, and it's inspissated with gunk, perhaps mucus, perhaps inflammatory stuff. And this is not only the cause of a chronic pancreatitis, but it could be the result of it as well. By the way, just out of curiosity, I know we're not in lab, but what do you think all of this stuff is over here in the southwest? What do you think that is? Okay, well, I got one theory. Yeah, most of the people are getting it right. Even though we're really seeing these are just a little cluster of lymphocytes. You could tell because they're so black and so small. Okay, like pepper. Okay, let's talk about the clinical features of chronic pancreatitis. Well, there may be abdominal pain, but it's certainly not as bad as acute pancreatitis. A lot of times the abdominal symptoms are regarded as vague. Most of the time, there are no features. There are no clinical symptoms. It is subclinical. Amylase, probably elevated, but not 10 times or 20 times normal. It might be only a couple times higher than normal. CT calcifications, we've already explained why. Because once that stearate hooks up with the calcium, you get soap, scum calcifications in your pancreas. If the pancreas itself is significantly impaired enough to not work, and malabsorption results, usually steatorrhea. Usually it's the fat that comes out in the stool much more. And there are very easy ways of measuring to see whether stool has fat. There's a lot of easy fat stains you could use. Now, let's get into the concept of pseudocyst. We said that pseudocysts and chronic pancreatitis go hand in hand. So what is a pseudocyst? Do you remember in your anatomy lab when you stuck your finger through the epiploic foramen, okay? And maybe somebody said to you, once you stick your finger from the abdominal cavity into the epiploic foramen, you then enter something that's called the lesser sac. It's also called the omental bursa, and it's generally outlined by this blue layer of mesothelium here. It's a big pocket, out pocket. Now, let me ask you this. It is a single, well-defined cavity. You have the stomach on one side, you are near the spleen on the other side, you have a kidney nearby, you have arteries and lumbar vertebrae nearby. But technically speaking, what would happen if there was enough inflammation in this area to close off that epiploic foramen? Remember, it's only about as big as your thumb anyway. So this whole big cavity has only one way out, and that's the epiploic foramen. If there was inflammation here from a pancreatitis, and that thing got closed off, that's your pseudocyst. So a pseudocyst is a expansion of the lesser sac, or if you want to call it the omental bursa, either way, due to closing off of the epiploic foramen. And do you remember, you may have seen in your anatomy lab somebody actually show you the anterior edge of the epiploic foramen. And remember, there was a little cord there, and in the cord you had both your main hepatic artery, you had your bile duct, and you have your portal vein, the main portal vein, all in one. And you knew that if you squeezed that, all of the main channels, going into your liver are completely closed off, which of course the surgeon's going to want to do if there's ever blunt hemorrhage into that liver. He's going to take that, he's going to go into the epiploic foramen, he's going to stick his finger in there and stick his thumb on the other side to cut off the blood supply to the liver if the patient is bleeding to death to the liver. So a pseudocyst is a result of chronic pancreatitis in which you have closing off of the epiploic foramen. And for that reason, it could be very, very big. It could be the size of a football. It could also be just partial or small, maybe the size of a grape. And once you have a pseudocyst, it can cause obstruction or compression of other organs. it could become infected as well. The one thing that pseudocysts never do is become malignant, because they're not even tumors. They're not even true cysts. They're called pseudocysts. So what's the difference between a pseudocyst and a real or non-pseudocyst? In pathology, if a cyst is lined by an epithelium, that's called a cyst. But there is no real epithelium in that lesser sac. It's strictly connective tissue and mesothelium. So that's why it's called a pseudocyst. And here's a small pseudocyst. And you can see it has a glistening surface there. It's definitely displaced or occupied part of the pancreas. But once again, it can also be extending into that lesser sac. Here is the edge of it, and you have some inflammatory cells and perhaps some mesothelial cells, but you don't have an epithelial surrounding. That's why it's called a pseudocyst. Now, on the other hand, look at, here's a big pseudocyst. This is virtually not only the entire lesser sac, but it is a large, expanded lesser sac. Look at, there's a piece of pancreas there and there and there. And here we have your spleen displaced to one side, and it probably has a nice fibrous capsule, but of course no true epithelium. That's why it's called a pseudocyst. Okay, let's look at the clock. Oh my God, we did 1 hour. So guess what? All we have to do in the next hour is talk about pancreas neoplasms, and we will. And then we'll have, I have only selected about 7 or 8 cases for lab. And the reason why I really, really like Pancreas Day is because I could show the slides immediately after we talk about them during our discussion. So it's an immediate synchronized feedback. It's not like you have to wait for a week or you have to wait for the next session to see the lab slides of the things that you've just discussed. It's like this. I wish I could do every day like this. That's why I like Pancreas a lot. So let's take our break. If you have a question, type it into the question box. I see there's a couple of questions already. I'll deal with those when I get back. And we're going to hear a couple, 2, 3 songs during our break. And remember, the first one was donated by our Russian friend, Andrei Zharov.
A long time ago in the country Mayo, this story first begun. Before this land it was finally cured by the first economical plan. A brave young man had to leave his home and sail far over the sea. But he got well paid on the job and he stayed on the shores of America. He got on very well, but he sent nothing home, and his father began to think that maybe he ran away with the blonde and he spent all his money on drink. She wrote him a letter, wiring the news, and sent it straight away. And upon the cover she carefully wrote to me son in America. Postman collected the letter she wrote, and he drove in his van to Cork, where he placed it on board of a ship in the cove that landed in New York. It's there with the whiskey and everything else, the mailbags lay on the quay, and among the rest was a letter addressed to me son in America. And American postmen I needn't relate, they are all like me and you. But when at last to this letter they came, they didn't know what to do. They looked up all the official lists, but these had nothing to say, 'cause there was no directory to help them to find a son in America. So it lay around the office for years and years, and it gave all the boys to laugh. Until one day it found some use in training of their staff. To every new postman who came on the job, it was shown as example A. That was insufficiently addressed to me son in America. But the son he got older and wiser too, and one day to himself he said, "Oh, how are things going with the mother at home in this shell I'm or dead?" He walked round the block to the chippy over his two with his top in his hand. By any chance a dear letter for me from my mother in Ireland. Yeah, she don't listen, Anna. She didn't go cast on listen. Oh, yes, kind sir, and dear it is, been waiting for you to call. When you have a one someday will come from Cork or old Donegal. From the 200 million that's living now in the whole of the USA. For mother in Ireland we finally found a son in America.
What kind of life would that be? Oh, I need you in my arms, need you to hold. You're my world, my heart, my soul. If you ever leave, oh, baby, you would take away everything good in my life. And tell me now.
emotions and my thoughtlessness. After all, I'm forever in your debt. I will try to express my inner feelings and thankfulness for showing me the meaning of success.
Well, we are back. We are back for the hour that's remaining, the second hour of our 59th session here. I didn't have any brilliant thoughts while I was recaffeinating myself, but I do have to make another tiny announcement. For the people that have downloaded the new MP4 movies, I know there was somebody there named John who said he did, but if any of you download them and watch them, I need for you to tell me, I need for you to email me and to tell me how they compare to the real-time sessions. I'm suspecting they're considerably better in quality. See, I really appreciate it when you all come here, but there are 20 times as many people who watch the movies from either going to GoPath and looking at them streaming or perhaps downloading them now. We know from our statistics that 95% of our registrants watch the sessions at their convenience and not ours, which is of course the way learning should be. When students are going into bankruptcy every day from not being able to take up enough loans to have enough tuition money, I think the very least you could give a person who's hacked their entire life is convenience of service. But anyway, I really do appreciate for you who come here live as well. Okay, last question is, was everybody able to hear me well during the first hour? I'm suspecting yes. Okay, that's what I thought. On my end, the technical stuff is going pretty well. Somebody asks, bid of a typo with the title pseudocyst. Yeah, I probably have a typo in there. Thank you, Scott. I'll create it. Can pancreas divisum cause diseases? I would say in most cases no. Remember, it's not that common. I would imagine if there's incomplete fusion, there may also be incomplete function, but that's just my guess. I think you're going to have to Google that one. The mechanism of alcohol causing acute pancreatitis. Good question. And I don't know the answer to that one either. All I know is that in a clinical setting, the cases we saw in the clinics of people with acute pancreatitis, they were almost always after a weekend binge. Maybe it's a direct toxic mechanism. Most likely it has something to do to cause the bile reflux. Maybe it has something to do with spasm of the sphincter of Oddi. That's my theory, but I don't know for sure. Somebody said, I tried to download the videos, but all it does is go into a QuickTime video. Well, when you look at the download message, there's a variety of ways to look at movies. You know, if you use Windows, they want you to use their little media player. You know, Apple always wants to use QuickTime. I found that there is a very quick, easy, simple, non-invasive program called VLAN, Video LAN, V-L-A-N. And I mentioned that if you want to see the best quality videos of all my videos, take the time to download Video LAN. That would be the solution to that one. Somebody said, please, Dr. Minarsik, are you going to repeat general pathology lectures? Well, don't forget, I've already given them several times. They're on YouTube. They're on GoPath Live. They're also in 2 sets of my archives. I'll probably do the whole course again next year, only because I have nothing better to do, and most medical schools hate me, so they won't give me a job, so I might as well keep doing this until I die, which is what, you know, I feel like this is a very, very worthwhile thing to do. Somebody asks, in pancreatitis, why is amylase is only to consider as a main enzyme? Why not lipase? Actually, all of the enzymes are elevated in pancreatitis, acute and chronic. They have found that amylase is the most reliable, sensitive indicator. But if you took all those other enzymes, you know, the procapsidase and all of the proteins and the lipases and so forth, they're elevated as well. Okay, that means we could get into the second half now and talk about pancreas tumors. And as you might guess, you know, all of these neoplasms look like they're glandular. And it's no different from what we talked about before. There are serous, acini, and ductal cells within the pancreas. There are mucinous. You can have a neoplasm that appears cystic. If the cysts are so small they're barely visible, perhaps only a millimeter or 2, that's called microcystic. So you could have a mucinous microcystic or a serous microcystic. Not surprising, you can have papillary neoplasms. Now, the papillary neoplasms are much more common in the head of the pancreas, because if you remember, the majority of carcinomas of the head of the pancreas actually arise in the ampullary area, which has kind of a papillary configuration anyway. So a papillary neoplasm, especially a papillary adenocarcinoma, would be much more likely to be in the ampullary head region. And of course, don't forget the basic classifications of benign and malignant. But I want to tell you something. We talked about breast carcinomas as having a dense fibrotic or a dense sclerotic response. We called that scarus, remember? It's also true with pancreas. Pancreas adenocarcinomas usually have a very dense desmoplastic or sclerotic or fibrotic response. So that is one of the things that's almost universally true. And that's why when you do a small biopsy of the pancreas, you don't always know right away whether those sclerotic glands are part of a pancreatitis and fibrous reaction, or whether they are malignant glands invading fibrous tissue. Sometimes it's very, very difficult to differentiate. Of course, if you see that the glands are surrounding nerves, or they're in perineural spaces, then it doesn't matter what they look like. You know that's malignant. So these are all things that are taken into consideration. Here is a adenoma that is cystic. It looks like it's serous because you don't see any mucus. And in addition, the cells themselves, look at their little flat or cuboidal, and look at, they almost look like a little sponge. This may be called a microcystic adenoma, because if you look at the specimen grossly, you can see that some of these cysts are barely visible to the naked eye. And even though you can see maybe 10 or 20 of them here, look, microscopically they're all over the place. So this would qualify as a benign serous cystadenoma, microcystic. Let's look at another one. Here's something that it appears benign because it's well encapsulated. It has nicely defined cysts. And look, when you look at the surface of these cysts, and remember, it's a true cyst because it has an epithelial lining. Well, this is a simple columnar mucus epithelium. You know it's mucus because look, the cytoplasm is very light and washed out. So this is a mucinous cystadenoma. It appears benign both microscopically because the cells are normal and lined up nicely, and the nuclei are at the base and they're behaving like nice little soldiers. Also note, you know it's benign because it's very, very well encapsulated as well. Now, here is a papillary neoplasm. And once again, if it's a papillary neoplasm, it's probably in the region of the ampulla or head. And look, you could even see the papillae grossly, can't you? You can see these little fingers just kind of growing out like little bushes. And microscopically, like all true papillae, they consist of a lining of epithelium with a central fibrovascular core. So, all I'm saying is that this is a papillary neoplasm. Whether it is a malignant papillary neoplasm or a papillary adenocarcinoma or a benign papilloma would be something for the pathologist to agonize over. And that might take into consideration other factors, like is it invasive, is it in lymph nodes. I think just from looking at this alone, nobody could really tell you whether this is benign or malignant. Of course, everybody would be afraid it's malignant, but it would take a real, truly great pathologist to say, this is benign. Remember, it takes a lot more courage and knowledge and experience and wisdom to call something benign rather than malignant. A lot of people call things malignant because they're afraid that if they don't call it malignant, the malpractice attorneys will send it out to some joker at a big ivory tower institution that'll call it malignant, and then they'll look stupid. This is a little diagram. I don't think it's necessary to memorize all of these stages, but you know, a lot of times we talk about the transition or the dysplastic changes or the hyperplastic and dysplastic changes which precede in situ and invasive carcinoma. And technically, there's your normal pancreatic glandular epithelium. Somewhere along the line, when it appears hyperplastic in terms of these cells getting a little bit larger and more numerous, and also maybe some secondary infolding, you are having some genetic alterations like telomere shortening. Remember, that's a very, very important step in carcinogenesis. And in this case, it's an early step. Also, the mutations of KRAS appear at the earlier stage as well. When you get into a more proliferative and atypical stage, you can imagine that the P16 may very well be inactivated as well. And then, of course, by the time you get inactivation of P53, you know, one of the most common genes to be mutated in neoplasms, that's usually in the so-called premalignant or perhaps severely dysplastic or in situ stages. And then, of course, the general feeling is that this whole process here could lead ultimately to an invasive carcinoma. Now, it doesn't have to, but that's the general sequence of events. So what are you going to remember about this? That in the early stages there might be some telomere shortening. In some of the middle stages there might be some KRAS mutations, and then P16 inactivation, then P53. These are all common genetic mutations in carcinogenesis. And isn't it interesting that they are associated, some of them, with earlier stages versus later stages. So just kind of remember that. Not necessarily the order, but we went to a nice talk on carcinogenesis and molecular pathology last week in the GoPath webinar, and our presenter was talking about some of the sequence of genetic changes that occur as well. Here's a pancreas cancer. I think you can all see it. You know that this is the body, this area here is the tail, but look at the head. You have, in the body and in the tail, you could still see lobular architecture. You could probably put your little pointer on any one of these little looking lobules and say, yeah, this is a lobule. But when you get to the head, grossly, not only do you have the lobular architecture gone, but it's replaced by fibrotic infiltrative tissue. So even grossly, you would probably say this is a pancreas cancer. Now, microscopically, you can see there's some more of the fibrosis going on within a normal, pinker, softer consistency. You have a hard, more fibrotic, irregular tissue here. And here we go on the right. And I know what you're thinking. You're thinking, when you look at the cancer on the right, you're thinking, well, gee, this really doesn't look terribly malignant. The nuclei kind of look like they're all the same size. However, it looks like they're not really quite fully developed glands, and there's a lot of fibrosis around them. So you're going to say, hey, could this really be chronic fibrotic pancreatitis rather than infiltrating adenocarcinoma? And actually, I'll have to be very honest with you, if I showed this picture to my friends or it appeared on a frozen section, I think a lot of people would be very hesitant to call it cancer. Because remember, even though pancreas is the easiest of chapters, it's the most difficult to diagnose from small biopsies. And everybody lives in great fear that they're going to call these little glands cancer and find out the next day that the patient lost half of his abdominal contents for no reason. It's a very scary thing. However, let me ask you this. Let's say that you saw these glands in question, okay, here and here, and you're not sure whether it's cancer or fibrotic glands, but they happen to appear inside of a nerve microscopically. Then it doesn't matter what they look like. If it's inside of a nerve or a perineural space, then what's your diagnosis? Benign or malignant? Yep, you all got that one right. Okay, what is the fate or the biologic behavior of pancreas cancer? Well, like most other things, we talked about those 5 different groups of peripancreatic lymph nodes. We'll just call them regional lymph nodes. That's the first area to metastasize outside of the pancreas, because the pancreas is completely drained by portal circulation. You could think of the liver as being the main lymph node for the pancreas. Often it goes to the lumbar spine, and it usually goes to the lumbar spine in the area where the pancreas is. And we said that's usually L2. It's upper lumbar, usually L2. Sometimes I've seen it L3. I don't know why, because technically, if it's a hematologic bony metastasis, and it's not a direct spread, you would think it'd be just as likely to go to the skull as it would be to the spine. But the fact is, I'll tell you from experience, because I've done a million bone scans, when you have somebody with pancreas cancer, the first place it goes when there's a bony met is the upper lumbar spine. Of course, lungs, and the reason for that is everything goes to the lungs eventually. There is a grading system to talk about how well or middle or poorly differentiated those glands are. If it's a well differentiated tumor, they generally behave better than poorly differentiated tumors. And of course, it's the well differentiated malignant gland that have a very, very hard time differentiating from a normal gland involved in a fibrotic pancreatitis. So there's a staging system as well, and there's a TNM. I don't think it's worth going into it, but you know, most of the organs now are using the TNM classification for how big the tumor is, give that a number, whether there's lymph node metastasis or not, and whether there's distant metastases. Now, let me tell you why pancreas cancer overall has a very, very horrible prognosis. And I'll tell you why. And here's the reason. Listen up, because this is very careful. I have some friends that died of pancreas cancer. By the time pancreas cancer produces any type of symptom, whether it's pain or whether it's jaundice or whether it's common duct obstruction, by the time it produces a symptom, it's already metastasized. Very much like lung cancer, isn't it? So, what is our final tip for the day, and also our final PowerPoint slide? Something very, very clinical, and I think I have to say it even though a lot of you may know it already. The final tip of the day is, if an elderly person, you know, and I'm not sure if I'm elderly, you know, I'm 64, but let's say somebody in their 70s or 80s, yeah, maybe I am elderly. Painless jaundice in an elderly person, painless jaundice, is carcinoma of the head of the pancreas until proven otherwise. Elderly person comes in, they've noticed over the last few days or weeks they're getting a little more yellow, they have elevated bilirubin. The very first thing you're going to do is get a CAT scan of the pancreas. Folks, that's it for lecture for today. Thank you for your attention. Take a real deep breath, and we'll maybe take 1 minute to see if there's any questions. No real questions, just a couple of nice comments. So let's walk down the hall and go into the lab now. Put on your lab coats, walk down the hall, you start to smell the stinky formalin, open the door, get out your microscope, get out your slides, hope that they're not broken, hope somebody hasn't stolen your microscope, plug it in, take 10 minutes to focus your eyeballs, and let's start looking at pancreas. Good place to look at the beginning is the world's most normal pancreas histologically. Remember, we said that pancreas is lobules. So look, there's a lobule, there's a lobule, there's a lobule, there's a lobule. Probably in this area here in the middle, there's probably 20 lobules. But look, lobules are separated from each other by fibrous connective tissue. So if you see a duct within a lobule, it's either an intercalated or an intralobular duct. If you see a duct between lobules, like there's a big duct over there, then that's either a interlobular duct, or in this case it looks like it might even be, you know, the main or the accessory pancreatic duct. Let's take a little bit of a bigger look at it. If that's an artery, I change my opinion. Yeah, that's an artery, that's not a duct. I was wrong. That's probably a splenic artery or one of the main branches going to the pancreas. Let's go back and look at a big duct. Oh, I don't know. Is this a duct? I bet you this is a duct over here. It looks like it might have some kind of epithelial lining. Nope, it's another vein. Maybe next to it there's an artery. Yeah, there's an artery, there's a vein, there's some fat, there's some nice acini over there, there's the edge of a lobule. Come on, let's find a big duct. Don't make me look stupid. Maybe this is a duct over here. Let's take a look. No, it's another blood vessel. Here's another smaller artery. Here's a vein. Maybe some of these might even be lymphatics. It could be very difficult to differentiate a lymphatic from a small vein, unless of course you see blood inside of it, then you know it's not a lymphatic. Is this a duct? No, it isn't. There's some more blood vessels. There's a nerve, by the way. You see that? Let's say that you were examining this pancreas and you saw some little glands in this little perineural space. Then you know it would be cancer, correct? Look, here's another branch of a nerve. I'm getting a little bit humiliated by not finding a good duct. There's some more nerves, isn't there? Now, the thing I want to point out to you, maybe we'll find a duct eventually, interlobular. But the thing I want to point out eventually is that when you look at a pancreas, you know, right away, you often can't tell whether it's a pancreas or if it's the other gland that produces amylase, a parotid salivary gland, because they're all 100% serous acini. The only thing that tips you off right away is to see these little light islands over here, like here and here and here. So you know, if this was a parotid gland, you wouldn't have these little lighter islands of Langerhans here. And here, let's take a good look at an island of Langerhans. And look, there's a beautiful one. Now, can I tell you the difference right now between the alpha cell, a beta cell, and a delta cell? No, not really. You'd probably have to do a special stain. They just all look the same to me. There's the tip of a islet over there. There's the middle of one. There's a big one. There's a big one. Let me ask you a question. Where are islets a lot more densely common in? The head of the pancreas or the tail of the pancreas? The tail. Isn't that kind of funny? Because the big part of the pancreas, the head, is where they have the least number of islets. I don't know why it works out that way. I'm sure it's some embryologic phenomenon. Okay, so let's say that you see a duct over here. This is a duct. This is probably an intralobular duct. Okay? Now, if you see a smaller duct than that, it's probably an intercalated duct. And I bet you that maybe this could very easily be an intercalated duct over here. In fact, you know what I'm going to do? I'm going to blow this area up. And you know most of these are acini. But look, do you see this little duct here? That's probably an intercalated duct, because it looks like it has the same kind of cytoplasmic staining as the centroacinar cells. So the spindly cells in the middle of the acinus, like maybe that, but they're sometimes round, but very often they look kind of spindly. These are the centroacinar cells because they're in the middle of the acinus. The nuclei that are at the end of the acillus, the basal side, are the regular old secretory cells. Okay, that's probably a intercalated duct there, and I bet you I could find an intralobular duct without looking too far. They're a little bit bigger than the intercalated, and it seems like that the duct gods are not with me today. This is a little bit bigger of a duct. That could be an intralobular duct. But you know what? For some reason, I'm not really finding any good interlobular ducts. And if I don't see one pretty soon, I'm just going to give up and quit. We've seen everything else. But look, this is a normal lobular architecture of a pancreas. Memorize it, and we'll just move on to another pancreas that was also called normal. But in this one, it looks like there's not nearly as much connective tissue. In this one, you can still see some lobules. You can still see some separation of lobules. You can still see some islets over here. But what we're going to see here is something that we didn't see in the other one. Look at, if you have a duct that's completely surrounded by fibrous tissue and it's inter or between the lobules, that not only be a interlobular duct, but it could even be a main branch of either the main duct or the accessory duct, or it could be the accessory duct. And what do you think this is over here? You know, this is probably an islet. Let's move around a little bit more and then we'll call it a day. Look at, there's a nice little lobule over there. There's a nice vein. There's a nice artery. And I bet you it wouldn't take a long time for us to find little branches of nerves as well. This is also another beautiful pancreas, by the way. And once again, I'm having a hard time finding interlobular ducts. This could very easily be an interlobular duct over here because it's bigger, and in my opinion it looks like there's a little bit of fibrous tissue around it. So yeah, this is definitely between lobules because it's completely surrounded by fat. Okay, we're done with normal pancreas. Let's talk about one of the most common, usually not serious condition of pancreas. It's called fatty infiltration. And in fatty infiltration, the lobules are even more separated by fat. Now, in the connective tissue between lobules, usually there is a little bit of fat, but in this case there's a lot of fat separating the lobules. This is called fatty infiltration. It's not fatty metamorphosis like you have in the liver. It's not fatty change, but it's given the name fatty infiltration because it's just normal fat infiltrating between the lobules. Look at, here's a very, very large duct. This is probably the main duct over here. And look, there's a beautiful interlobular duct. And look at, there's an islet, there's an islet, there's a lobule. And let me tell you what fatty infiltration of the pancreas is associated with. It's associated with fatty infiltration of the entire body. So, are obese people that have a lot of fat everywhere more likely to get fatty pancreas, just like they have a fatty abdomen or a fatty mesentery or fatty subcutaneous? Yes. And it's usually asymptomatic, but it's kind of cute to see this every now and then at autopsy. Now we're done with fatty infiltration. Here, you know what? I'm going to pop out the box here because I'm going to start asking some questions. First of all, I think you probably already know what the diagnosis is. You could say it if you want, but whether you say it or not, I want to show you something. Do you see how this entire pancreas is just loaded with hemorrhage? Do you also see how, where in parts of the pancreas you could make out individual cells, but in some parts of the pancreas it looks like these cells are being digested? In other words, no nucleus. Can you also tell that there are a lot of neutrophils here as well? So this is a very, very incredibly easy diagnosis of acute pancreatitis. And let's see, what else do we want to say about it? We're actually nothing. I think it pretty much demonstrates what we talked about before. There's an interlobular duct over there. Oh, do we see some islets around? If there are islets in this area, you know that they're being damaged also. But if this is in the head of the pancreas, you may not see very many islets. It looks like there's a big artery there. And it just looks like a mess. It looks like a partially digested piece of meat because it is a partially digested piece of meat. Now, can everybody hear me? Because somebody thought they lost their audio. Please tell me if you could still hear me. Yeah, John, everybody can hear me. So if somebody can't, it's your fault, not mine. Let's go on to our next case. Now, this is going to be a pancreas. I think you'll instantly recognize that because number one, it looks like a salivary gland. And on number two, I bet you if you looked hard enough you could find some islets here. Now look, here's some normal lobules in the northwest, but most of the rest of these pancreas tissue looks like there's a lot of fibrosis between lobules. In fact, you're probably even wondering if this could be a sclerosing adenocarcinoma. Now, when I first looked at this slide yesterday, can I tell you something? I was scared. I thought, could some of these little glands here really be infiltrating rather than just part of a sclerotic pancreatitis? And furthermore, so the first thing that I did when I saw this is I went to where all these nerves are. Here's a nerve, here's a nerve. Are there some more nerves? Maybe, maybe not. Oh, there were like 5 or 6 nerves I went to, because I'm thinking, could these sclerotic glands be a well-differentiated infiltrating adenocarcinoma, or could this just be a chronic pancreatitis? This is a very, very, very scary thing, folks. And if you were to just see this field only, I'm telling you, half the pathologists would call it cancer and half of them would call it chronic pancreatitis. But the other half that doesn't exist would be intellectually honest and they would say, I really don't know. And you know, that's really a no-no word in pathology because everybody likes to pretend like they know. But look, here's a nerve, here's a nerve, here's a nerve, and there's no little glands around these nerves. So, would you regard this as a sclerosing adenocarcinoma or a chronic pancreatitis? Just give me your opinion. Let's just say the only thing we could see is that there's no nerve involvement. But so most people are saying chronic. But here, okay, that's right. You got the right answer. But let me ask you another question. I want you to be honest. Let's say that this was the only thing that you saw. And I was to say, is this chronic pancreatitis or is this infiltrating adenocarcinoma? Oh, somebody says, where's the calcium? Hey, that's a good question. Guess what? There isn't any calcium in this one. I don't think I saw any calcium, but there should be, right? It just happens in the slide that they took the section from, we don't have calcification, but we have a lot of fibrosis, don't we? So anyway, when I finally looked at the answer to this slide, rather than just looking at it blind, I see that they called it chronic pancreatitis. And I would justify that diagnosis simply because even though there's a lot of fibrosis, it still maintains a lobular configuration. And also, there's no infiltration of the nerves either. Let me just see if that's a little nerve up there. And actually, it is a little nerve, isn't it? But look, there's no infiltration. There's a nice little separation between the fibrous tissue of the lobule and the fibrous tissue of the nerve. So that nerve is not involved with it. But you see that little space there between the nerve and the fibrous tissue surrounding the nerve? Let's say that you saw one gland there and it looked just as normal as these glands. Then what would your diagnosis be? Absolutely. I think you got the right idea. Actually, you're doing more than just being good medical students. You're actually starting to think like pathologists now. Let's look at another pancreas. And, well, here's some lobules down here at the bottom. And generally, there's some glands up here at the top, but they don't really look like they are forming a lobular sort of configuration. And in addition, there's some glands here on the right, and they don't look like they're forming a lobular configuration, but you know, there could just be a lot of fibrosis in them. So, here's what we're going to do. I know right now you're probably wondering again, is this cancer or is this chronic pancreatitis? So let's look at the normal stuff first. I'm going to take a section through this beautiful lobule down here. And you can see a lot of intralobular ducts. You can see acini. You can see central acinar cells. This looks actually like maybe normal or maybe a little bit of chronic inflammation. What do you think this thing is over here, by the way? What do you think this little round thing is? Yeah, it's a tip of an islet, I think. Okay, well that's another reason why this is probably just a normal lobule. Now, let's go back to low power and let's take a look at some of these glands over here on the top where it doesn't look like it's conforming to a lobular architecture. Okay, ladies and gentlemen, is this an easy diagnosis for you, or do you want me to describe it? Yeah, this is cancer. This is irregular glands, and luckily enough, they even look malignant from a cytologic point of view. Look at the extreme pleomorphism and hyperchromasia, and look, that's a mitosis that looks like it wants to go in about 6 different directions. You know, this you could tell is cancer no matter what, okay? This is an easy diagnosis. Now let's go see if we could find some involvement in some perineural structures. I didn't look last time for perineural structures, but we could make a quick look. Oh, let's say that we look here on the right, and we'll just make a quick little statement of whether we see nerves or not. And if we see some of those malignant glands in the nerve, then we know it is, but it'd be nice to demonstrate it, and I know we've seen it before, but I don't really see any nerves here. And if I did, I would point them out, and if they did, I would also hope that they were infiltrated. Okay, no nerves, but still, that doesn't matter. We know this is infiltrating adenocarcinoma. Easy diagnosis because it's not well differentiated. So when you want to grade this thing, if you had to say well, medium, or poor differentiation, what would you say? Well, medium, or poor? I see most of the people are saying poor. If you said medium, I would probably agree with you, but it's certainly not well differentiated. And look, some of these things are just like almost individual little cells. And you could always look at this later on in Rock Lab, and if you could find some perineural involvement, you know, you might be able to find it on your own if you want to. Okay, we're done with that case. Do we have another one here? Yeah, I want to show you something interesting now about the pancreas. And I wish I knew a lot about it, but it's a very common finding. You see this here? That's pancreas. You can almost tell the lobules even from the thumbnail. And here's another pancreas. You know, maybe there's a little bit more fat between those lobules as there should be. But I want to show you something here. There's a little bit more fat in connective tissue, so if you wanted to call this a little bit of fatty infiltration, that would be okay. But what is the thing that really sticks out here? It seems like there's a lot of islets here. See, look at all those. They're big. There's a lot of them. And in addition to that, you would think, well, if this section is a section of the pancreas, it's probably from the tail because the islets are very, very abundant. But not only are they abundant, but they look bigger than normal. So let's look at the islets in this case. We'll zoom in on Nevada here. And you got big islets. In this case, the islets are comprising about, 30 or 40% of the lobules. Normally, it's a lot less than that. And not only are they big islets, but they are hyalinized. So somebody, in fact, 4 people already said, as an instant knee-jerk reflex, could this be amyloid? And the answer is, yes, it could be amyloid. Now, can I ask you this? Could it just be regular fibrosis as well? If you did a trichrome stain and all of this pink stuff was green, then you would just call it fibrotic or sclerotic islets, right? But let's say that you did a Congo red stain and you did a polarization and it was a granny apple green, then you know it's amyloid. Now, here, no matter what it is, let me ask you this. Does the exocrine portion of this pancreas look normal? Absolutely. Does the endocrine portion of this pancreas look normal? No, we have sclerotic or hyalinized islets. So what disease do you think this patient has? Absolutely, diabetes. Now, the average type 2 diabetic, which seems to be an epidemic around the world right now, probably has normal looking islets, because as you know, type 2 diabetes is not necessarily a disease of insulin underproduction, but it's probably more of a disease of insulin resistance peripherally. So most of the diabetics, you do autopsies on them, they're going to have rather normal looking islets. But let's say that this was a type 1 diabetic. Remember, that's an autoimmune disease. These are the people that have autoimmune inflammation in their islets at a very early portion of life. Let's say that you've had an ileitis, an isletitis due to type 1 diabetes. Well, what follows inflammation? Fibrosis follows inflammation. So, let me ask you this question. Is this patient more likely a type 1 or a type 2 diabetic? I agree, it's more likely a type 1. And quite frankly, I don't know what this hyalinized material is. It could be amyloid. Let me tell you, sometimes you can have amyloidosis of the islets, okay? But on the other hand, without the stain, all I would do is call this hyalinized, which is a very common finding in type 1 diabetes. Sometimes in type 2, but usually type 1. Okay, we're done for the day, and it's also 10:56. So that'll give me a couple minutes to see if you have any questions. And don't forget, I don't discourage you from using your microphone. Sometimes most people feel a little bit better doing their questions in chat because it's a little more precise. And sometimes I ask questions better in chat because if I get a wrong answer, I don't want people listening to my stupid mouth. I don't see any questions. Somebody said, could this be an insulinoma? And my answer is no, because it is not a neoplastic proliferation of the islets. It's a hyalinization of the islets. One of the slides here had a islet cell tumor, and as you know, an islet cell tumor could produce insulin, it could produce glucagon, or it could produce gastrin. Those are the three common things. But we'll be getting into that more in the endocrine chapter. Why do you say it's diabetes 1 instead of 2 in the last slide? I'll tell you why. Because most type 2 diabetics do not have actual inflammation of their islets. In fact, most type 2 diabetics happen to have no pathologic changes. Now, I know that this was labeled as type 2 diabetic, so all I'm going to say is I don't like that label because normally you don't see pathologic changes with type 2, but in this case they labeled it type 2. Somebody said, I am not clear the basic as to why nerve involvement in malignant pancreas cancer. Very simple. If you have glands and you're not sure whether they're benign or malignant, but they happen to be inside of neural spaces, then you know normal glands don't have the capacity to invade nerve, but malignant glands do. So I hope that that answers your question about invasive glands. Why should we look for calcification? Is it associated with chronic pancreatitis? The answer is yes, it absolutely is associated with it. You may see it microscopically, or more likely you'll see it on CT scan. But if you have a pancreas that has not only fibrosis and chronic inflammation, but calcification, you know that that's chronic pancreatitis. Is nerve invasion specific to the pancreas? Absolutely not. You see it everywhere. You see it in salivary glands. You see it in breast. You see it in prostate. Any glandular organ that has an adenocarcinoma and there's nerves nearby, the nerves can very easily be invaded. That's the answer to that question. Any more questions? Okay, well, let's call it a day. It's already 11 o'clock on the dot. You've been working hard, so I'll let you go home now. And we'll pop the question thing back in. And one of my favorite songs we will close off with by one of my favorite groups, the Eagles.
Desperado, why don't you come to your senses? You've been out riding fences for so long now. Oh, you're a hard one, but I know that you got your reasons. These things that are pleasing you hurt you somehow. Don't you draw the queen of diamonds, boy. She'll beat you if she's able. You know the queen of hearts is always your best bet. Now it seems to me some fine things have been laid upon your table, but you only want the ones you can't get. Desperado, oh, you ain't real young. Your pain and your hunger, they're driving you home. And freedom, oh, freedom, well, that's just some people talking. Your prison is walking through this world all alone. Don't you think it's cold in the wintertime? The sky won't snow and the sun won't shine. It's hard to tell the nighttime from the day. You're losing all your highs and lows. Ain't it funny how the feeling goes away? Desperado, why don't you come to your senses? Come down from your fences. Open the gate. It may be raining, but there's a rainbow above you. You better let somebody love you. Somebody love you. Better let somebody love you. For it's too
Rock on, you desperados.